Okay, we're going to talk about something a little bit different. We're going to talk about L5 radiculopathy associated with ALIFs. We all love the ALIF because we can put in a large single lordotic cage, and we can also get indirect decompression. Unfortunately, one of the complications is nerve root injury, and we'll talk about this. We'll talk about what is the rate, what are the mechanisms, can the occurrence be reduced, and what are our treatment options should we have the unfortunate complication. If you look at the anatomy of the L5 nerve root, it's a little bit different than all the other nerve roots. In fact, you can see how it exits between the transverse process and the ala and then goes anteriorly. There isn't a lot of space there, and particularly if there's collapse or asymmetric collapse at that level. And if we look at the literature, these authors reported 7 out of 111 patients that had L5 nerve root irritation, but in 4 out of the 7, there was really no obvious cause. In this study, they reported on 2 cases in which it was due to screw misplacement from an anterior interbody cage actually traversing the pedicle of S1, injuring the S1 nerve root. We also had looked at the incidence with disc replacements from the ActiveL trial, and we found that we had 26 patients that had early onset leg pain, and 80% resolved within 3 months. 3 of the 26 had surgery, and none of them resolved. Now, this was another paper that we looked at, looking at all of our ALIFs, TDR, and hybrids to the efficacy of neuromonitoring. And we found that we had 2 neurologic deficits, both foot drops, with false negative monitoring. In other words, there was no change. One resolved within 3 months, and the other didn't resolve by 18 months. And then we had the paper from Ali's son and Shiraz, and I'm not sure what you guys were doing, Shiraz, but you reported on 34% of 140 patients with early onset radiculopathy, but fortunately they resolved by 83 days. And the risk factors, which I'm not sure really how to put these in perspective, were the use of prednisone, increased implant height, and no posterior fixation. So you have to interpret this data with caution because we don't understand the interplay with these factors with the severity of the problem that they were treating. So what are the mechanisms? Well, one we think may be stretching of the nerve root with the distraction of the collapsed disc space. The second, malposition of the implant and/or screws, or unrecognized foraminal spurs that the MRI was read as a disc protrusion that may cause compression with a hyperlordotic cage that doesn't give enough posterior height elevation. And the fourth one is compression by the retractor blade slipping over the side of the vertebral body, compressing the L5 root against the sacroiliac. I personally have had 2 of these, one resolved, and the other, unfortunately, was a permanent foot drop. But in each case, I noticed that on the fluoro, the fellow was holding the retractor into the neuroforamen. So it's very, very important that the surgeon, his assistant, and the x-ray tech be very, very cognizant of where the retractor blade is when you're checking films during the case. So what about the treatment strategy? Well, again, from this previous paper, first you have to assess for neurologic deficit, and if present, a CT scan is done to rule out any bony stenosis or soft tissue compression. Depending on the patient's symptoms, you may or may not want to investigate with Doppler to rule out a DVT. But once you've decided that there is nothing that you have found that surgical decompression will help, you either use oral steroids, Lyrica, or Neurontin, a selective nerve root block, or a combination thereof. And then you slowly increase the Lyrica or Neurontin, and then finally, if Cymbalta is not contraindicated, you can use that, but you should do no surgery in the absence of any obvious compression. And the worst case scenario, very rarely you might consider a temporary spinal cord stimulator. This was a case of mine, a patient from Canada who had a recurrent disc at 4 or 5. They wanted to do a fusion. He did not want that. So he came to see me. We were going to do a TDR at 4 or 5, but he said, well, I have foraminal stenosis at L5S1, one of these very, very well-informed people. So I do the surgery. He gets, of course, new right-sided ankle numbness and tingling that progressed to pain. We put them on medication, not getting better, driving me crazy because we're talking every other day from Canada. And then finally you get a CT scan. As you can see below, unbeknownst to me, there was a large foraminal spur. So we got him a selective nerve block. By 6 months, his pain was gone. He's now a happy guy. But what I've learned is that I'm getting more and more CTs because the MRI scan can fool you. So it's difficult to determine the true rate of post-op radiculitis due to variation in surgical decision-making, the techniques, and the definitions and reporting. With TDR, we know it's about 10%. So generally, they're not treated with surgery unless you have identifiable nerve root compression, which is almost never. And you should have a low threshold, get a preoperative CT to prevent falling into the trap of a disc protrusion masquerading as a foraminal spur that will not indirectly decompress with distraction. So surgeons who do the surgery should be aware of this, and you should counsel your patients preoperatively that it may happen. And after ruling out iatrogenic nerve root injury or DVT, then treat them medically and aggressively. In most cases, will resolve in 3 months. Thank you.